Start. So hello, everyone. Thank you for those of us who are joining on the Zoom and those who are on Facebook Live. Please let me know if you can hear me. I hope that you can. We're super happy to have Dr. Vidato with us tonight. I'm Tiffany Grunwald. I'm the Executive Director of the Women's Health and Wellness Institute, which is a new institute at St. John's, and we are kind of all about comprehensive women's health care across the full spectrum of healthcare and the continuum of our lives, which go through multiple hormonal shifts and events that take us by surprise. And some of those take us into surgery, which is some of what we'll be talking about tonight. Also, there's a lot of things that we do, like a colonoscopy, which also involve anesthesia. So we'll be able to talk about those. And please put your questions in the chat on the Zoom, and we'll talk about those, or comments on the Facebook Live. And I'll make sure that Dr. Vidato gets to those. Hopefully we'll get to everything tonight. We have a lot of myths to talk about, because everyone has so many myths around anesthesia, right?
Yes. And it is a science. Believe in the science.
It is a science, and it's changed tremendously. So Dr. Vidato, will you start us out by just kind of talking about what your training is and how you got to be an anesthesiologist, and then what your practice is, what you do on a daily, weekly, kind of monthly basis, and what the full spectrum of that is?
Oh my gosh, and that is on the spectrum in and of itself. My training, I graduated from med school at Brown University a long time ago. Initially matched, which we do, with internal medicine. So that had been the specialty that I was so excited about until near the end of right before graduation. I took an anesthesia rotation sort of on the fly. You could do it and then kind of get out early. And I said, oh my gosh, I'll choose that. And I wound up going, it was literally about 3 weeks before graduation, and I fell in love. Oh my gosh, that's, sorry. Let me put that on. That's my niece. Sorry about that. I forgot to
no problem
do that. And I wound up falling in love with this specialty. And this was doing a 2-week rotation where I woke up early at 6 o'clock, excited to get there. They said you can get out at about noon, and I had nothing to do with that. I would stay late, and it was really a good rotation. And then I came back to Los Angeles. I did internal medicine, the entire residency. I thought about cutting out, but my mom, who was a nurse, said, if you finish it, if you start it, you finish it. It doesn't make sense if you don't. So a lot of the things that I do are really involved with decisions, not just for me, but also involved with my family, which is sort of how I based my practice in. And then I finished medicine residency on a Friday. On a Monday, I started an anesthesia residency. And so now I'm going now for an entire new residency. I completed that all at LA County, USC, which I forgot to say. And then I did a fellowship in cardiothoracic anesthesia. I was a professor for a short period at LA County, USC. And then I've been in private practice since 1994. I've been at St. John's since 2004, and I'm a partner since 2008. What was the other question? I think that's
excellent. So the other question is, so that's great. I trained at LA County too, so I love that you were there for those years. And just so everyone knows, the internal medicine is 3 years, and the anesthesia is 3 years as well, right?
Yes, a total of 3 years. Then you tack on is 4 years.
Then the cardiothoracic.
Yes, with internal.
Yeah, so that's all after medical school, after you're a doctor. And now she's an anesthesiologist at St. John's, who I am blessed to work with, not as frequently as I'd like, but definitely frequently. So tell us kind of what your practice is like now, what kind of cases you do, so that people understand what anesthesia is, that you can do things that are as complicated as cardiothoracic. You can also do simpler things. I know you do some OB. So kind of what's your practice like?
I'll give you this week. We'll take a week.
Perfect. Okay.
Yes. And the week in my life of my practice was started with obstetrical anesthesia. So I was on call doing OB. And during that time, it is really geared towards providing anesthetic care for women in labor and their partners that are in labor. So I was there for a 7 o'clock shift at night, and I worked straight until about 4, 5 o'clock in the morning, putting in epidurals. You also, so the primary practice there is to really, one, make the mother comfortable by doing an epidural, which is a regional anesthetic. Also the preparedness for anything like a C-section if needed, or any kind of emergencies that can occur with women's care and the delivery of a baby. There's so many different things. And then I had a shorter day where I was in the GI lab, where I was doing bone marrow biopsies, and where they do colonoscopies and endoscopies. And that's a different type of anesthetic where you're giving sedation. But I'm required to be there, one, to monitor the patient, which is what we do on a daily basis. And in addition to that, it's not just monitoring vital signs, it's also, I am an airway manager by trade. I want to make sure that you're breathing well, that your heart is doing well, all of those things. And so I will be there, and if propofol is given, which I do give daily, I need to watch you to make sure that you're breathing. And I'm watching you very closely. Not just that, to make sure that you're comfortable, and the experience is one with which you come through seeing me in my practice, that you're comfortable, that you feel okay, and that you feel safe, and that you can get through this in a pretty good basis. And then today I did primarily orthopedics, where I did the anesthetics for shoulder arthroscopies. For an older gentleman where I had to do a regional block for someone who had a fracture of a radial fracture in their wrist. And then that was, and then another surgery where I did a young woman who had to have a hysteroscopy for fibroids. So this was just my day.
Which is a huge spectrum.
It's a huge spectrum
yeah.
of anesthetics, and it covers the entire breadth of sedation, doing a regional block of just a limb, doing a general anesthetic, all in one day. And so that's what I love about it the most. I can do so many different things during my day that it makes it still, even though I've been in medicine for, I'm 62, I shouldn't say that, but I'm not afraid. Okay, and I've been doing this.
I love that. I love that. Good for you.
Yes, I'm doing this for 30 years and been in practice since 1994. And I'm still excited about the practice in and of itself. It still brings me a lot of joy.
So that's great. And you know, that breadth is amazing. And I think we should talk a little bit about that. And you guys, please put your questions in if you have them about surgeries that you've had or that you might have in the future, because, you know, when I talk to patients, and sometimes I throw out words like it's going to be general, or it's going to be MAC, or it's going to be local, and people don't know what that is. And then sedation and regional block, which you just spoke about, I don't use, but I think people don't really know the difference between that. Can you kind of just go through each of those levels and what that means about if you're awake and what you're feeling and what your recovery is and why you would pick one versus the other?
Well, one of the biggest issues, and we'll start with some of the basic definitions, will be what is anesthesia. And it is a sort of a reversible dynamic of being able to provide a certain lack of awareness, either with a nerve or with consciousness, that wears off and then goes away. And one of the ways with which we look at things is, what is it? A lot of my day, just if I went through just this week of what I did, my anesthetic will be tailored to the type of surgery that is going to be done. So there are different types. Number one would be just local anesthetic, where you don't need me, but the anesthesia in and of itself is actually there, providing you with some degree of comfort, like in a dental procedure or just a very basic removal of a mole. Next would be we can use a combination of local but sedation. And the sedation can be anywhere from where you have a certain degree of awareness all the way to loss of consciousness. And that will take you from the spectrum of just pure IV sedation and what we call monitored anesthetic care, which is a MAC. And with that, if I'm giving you a drug like propofol, you really are asleep and you really are unconscious and unaware of what is going on. So that is MAC and IV sedation. That can be coupled with the surgeon doing a block, like a paracervical block for a hysteroscopy, or for a DNC, or for so many of the other things where someone is just doing a bunionectomy. This will be accompanying that particular procedure. I will give sedation at times where I'm doing a spinal or an epidural, but only for those procedures that would be requiring a different type of surgery. And I'll explain what that means. For women that get epidurals, usually for labor, they're wide awake. I'm gonna put them on the spectrum of the bravest of all. They're awake for everything that is being done, because whatever I give them intravenously will go to the baby. So we prevent that as much as we can. If you're coming in to get a knee replacement or a hip replacement, and I'm doing a regional for a spinal or an epidural, but it's mostly spinals, then I will sedate you. You may not know what is going on around you. You will even talk to me and we'll have a conversation about so many things that stay in the operating room, so don't worry about that. And then I can do that particular procedure, and then we kind of move on. So that is one depth of sedation. The other would be a general anesthetic. And with that, I'm providing an environment where you are completely unconscious, and the anesthetic is where I am actually putting you to sleep, monitoring pain, and making it so that you don't move. It's kind of the whole spectrum of providing amnesia, analgesia, and we don't want you to move for the surgeon. And that is done by putting you completely asleep. So I hope I kind of explained the spectrum.
Yeah, that's great. I think on that last one, so you said when you're under general, so amnesia, which means you're not going to remember anything.
No.
Analgesia, which means that you're not going to experience pain. And you said you monitor pain. So how do you do that if the patient's completely asleep?
Well, I'm going to sort of expand upon that, because some of the aspects of pain management, which is what we do, anesthesiologists are physicians that provide anesthesia, pain management, and critical care. This is sort of the spectrum of what we do. I will know the depth by monitoring your vital signs. And then there's also other monitors that I can use that can help me in providing sort of a gauge of what your depth of anesthetic would be. And that's called a Bi-Spectral analysis monitor. And I could have a whole spectrum of where I can always keep you at a particular point and titrate in medicines that keep you comfortable and keep you unaware and keep you without pain. I hope that explains.
Yeah, absolutely. I think that's great. We've got some great questions coming in, but since you're talking about this and what our monitors are now, I think it's a great place to kind of talk about one of those great myths that is out there that's in some old movies, and patients wake up during anesthesia, or they remember people, remember hearing their grandfather or their uncle say they woke up during anesthesia, they remembered it. So, I know there's been a lot of great changes in anesthesia, and, you mentioned propofol, like that's a whole new thing that wasn't around then. So between monitors and drugs, how has anesthesia changed, and what about that myth about people waking up during anesthesia?
One of the aspects of, that's I have to say wow like 50 times. One of the important aspects of anesthesia would be not that we're just giving you these drugs and they're supposed to do some kind of work, but I have to be able to look at what risks are there. Meaning, if I'm doing a surgery because someone had a gunshot wound, or someone's heart doesn't function very well, or someone is sick and they're what we call septic, their body is sort of in a tenuous state. So most often than not, that particular type of patient, I will be gentle with what kind of drugs I give them because they're sort of in a teetering sort of thing of where life and death occurs. Most often than not, I've done thousands of anesthetics, thousands of them, and I've never had any issue with awareness. So the only time that I've really had to give something that is very small and that awareness could occur is when you're dealing with patients who are elderly and their heart is not functioning, or someone who's bleeding, someone who's had a certain type of trauma, someone who is very, very sick. And in those cases, awareness would be something most often that could possibly occur. And if it does occur, usually we can tell and get you back to a state of comfort. You might be aware at that time, but you still won't feel any pain. That is usually the area where a smaller amount of anesthetics are given. Most often than not, people on a larger breadth of the spectrum are healthy, and I've never had those issues. So I'm just trying to give the scenario with anyone with certain what we call comorbidities or health problems that would make it so I'd have to be very gentle with what I give. I hope.
Yeah, and it sounds like what you're saying is that, and this is clearly one of your skills because I've worked with you so often, is, you know, you really take into account who the patient is. We, you know, provide all of the medical history and you talk to them, but there's a much bigger range of anesthesia than used to be available, that you can tailor it to the patient.
You can tailor it to the patient, where I can make it so I can give you exactly what it is that you need. And then I have it's not just an anesthetic. I'll give you an example. My specialty is pharmacology and physiology and anatomy. And I'll put those all into a spectrum. So I have a cart that I come in, and when I open that cart up each morning, there's a whole barrage of drugs that allow me to keep your blood pressure appropriately. In the right place, to make sure that your heart rate is in the proper place, that you don't get nausea, that anything that I might use like a paralytic, which can be used during a general anesthetic, that makes it so that I can put a tube in to help you breathe. Those things are all there, and the reversal agents for them. Any kind of emergency drug that I know of, it's all there. So I can actually titrate, give, monitor, intervene, do all of those things in a moment's notice by looking at what is going on with you with monitors and looking at you personally while I'm taking care of you. So there's so many different things.
Yeah, it's an art for sure.
It's an art for sure. I've never had anyone aware though.
That's good.
Yes.
That's good. That's a great thing. So we have a question about, is there truth to the idea that an older person who gets anesthesia doesn't bounce back to the cognitive level as they had prior to anesthesia? And this is kind of one of those myths also, right? Does this open the door to early dementia? No, it does not. But there's different things. One of the things with any anesthetic, be it a general, be it a MAC anesthetic, where I can give you something to make you completely asleep, but almost a general, but not quite, something that is still a sedative in any way, shape, or form, will make you not remember what is going on. And then once that wears off, your memory comes back, your awareness comes back. You can come from the operating room. I'll have patients go, okay, are we going to start surgery now? And I go, no, we're all completely done. And they're shocked, like, no way, this couldn't have happened. But there are certain patients that may be prone to the effects. There's post-operative delirium, and there's post-operative cognitive dysfunction. Post-operative delirium can last for just a short amount of time. And even for us, we will say, do not leave here and go and sign any important documents, like sign your home away. Give yourself at least 24 hours to 48 hours before you're really clear and everything is cleared away. But some patients might be prone to having these effects last longer, especially patients
who have cognitive dysfunction to start. So if they have Alzheimer's or any type of dementia, maybe someone who has really severe cardiac disease, puts them in the category of risk. And that risk would be something of where this could last a little bit longer. But that is a small percentage of patients.
Excellent.
Yes.
So I have another question. You talked about the different kinds of anesthesia, and some where you're awake and some where you're not. So why would you want to be awake? Sometimes I have patients who I'm doing something where they're having awake anesthesia and they're like, no, just put me to sleep. Just put me to sleep. So can you talk about kind of the pros and cons of being awake or using a lighter anesthesia where you might still be awake as opposed to just under general, you're completely out?
That's a pretty large question. So I'll deal with one aspect of that, and that might be the procedure in and of itself may not require something of where you're you need to be completely under a general anesthetic. Some people, it may be a control issue that they want to, maybe out of fear, want to know everything that is going on. And if the procedure is such that we can actually do that, then there's really no problem with that. And then the other would be is some things you need to go to sleep for, the surgery. And I hope I'm answering the question.
I think so. I think the question is, and if you want to clarify, you can put more information in to ask the question, but it's why would you want to be awake or asleep, or I think maybe it's about
choice.
If you just wanted to be asleep for everything. Could you ask for that? Like if you just want to be completely out, what's the disadvantage of that?
It may not be needed. And we can give you things that you don't necessarily remember. And what is out, it's sort of not a nebulous term, but it's something of where if a person prefers that, it would really be the type of procedure that's being done. If you're doing something in an office, it can be really done in an office. It depends on the comfort level, I think, of most people. And
which kind of, there's another question about, the question is, can you choose your anesthesiologist? But I think probably the bigger question that you can kind of help to answer this is, when you talk to your anesthesiologist, what do you want to know? And I know I've had some patients who have a friend who's an anesthesiologist, and they come in and they're like, I want you to do my anesthesia this way. This is what I want you to do. And I always say, when you have an anesthesiologist who's skilled, you want them to do it exactly as they're skilled. So like, what are those issues about choosing your anesthesiologist? Or most patients show up in the morning, right, and meet their anesthesiologist.
Correct.
So talk a little bit about kind of comfort levels with that, and what patients should be thinking about with that situation, which can sometimes be uncomfortable. Like, I just met you this morning and you're putting me to sleep.
Yes, yes, but that's true, and that's sort of gosh, you kind of caught me of where I'm not lost for words, but I understand it. And I understand that you're seeing me for the first time. And this relationship that you have with me is one that is very brief in the making. That's number one. So you don't know who I am. And then the other would be is that people come with a lot of information and a lot of concerns. I stop at that moment and say, look, we need to put it all out on the table. I need to talk to you about what it is that I can provide. And you can talk to me about what it is you want. And we can come to a consensus about what it is that we need to do. And then that's how there's approach to, I want you to do this, 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 and that. And I go, well, I need to tell you that, sometimes some of the things that you may ask for, most probably I want to kind of delve a little bit of what your concerns are. And that may be the biggest thing. Can you talk about what your concerns are? And then we will be able to sort of develop a plan. The anesthetic plan in and of itself really does involve the patient. It really does involve you being able to talk to me and tell me what you feel. And I have to be able to, and I say this all the time, I have to be able to answer the question or find out the answer to that question, or maybe we should be doing something different, meaning you should have a voice in it about what it is you think is important for you. And I'll take the time and talk. And I usually talk to patients most often than not the night before. So we've started.
I know you do. You're an amazing anesthesiologist, and you do relate to patients and ask them questions. And look, it is, you're right. It's a relationship that starts quickly, but you know, it is about getting to know that comfort level. And I think that's so important, and you are skilled at that.
Right. And I think part of it could be if you didn't have a friend, what are some of the misconceptions, or what are some of the questions have about who are you, and really what is an anesthesiologist? And some people may not know that I'm a physician, and they may not know that I've gone through a lot of training. I may get asked, hey, are you really there in the operating room? I go, yeah, that is my office. This is where I practice. This is what I do. This is, and I will be watching out for you as if you are a family member, which is very important. And I think that even a lot of people in the practice that I have were really vigilant and watch out for you as if you are their own. And so that's important to know.
Yeah, I love that.
Yeah, and then we have to work through what it is that is there. What procedure is it? And does that procedure allow you to have a particular type of choice? For a knee replacement, you have a choice. I could give you a general, or I could give you a spinal or epidural. If you're having brain surgery, there's no choice. Or do you see what I mean? So
yeah, really absolutely.
Yeah.
So you mentioned something, and you know, obviously at St. John's, we're fortunate, and every surgery has a anesthesiologist who's a physician.
Correct.
As you are, with extensive training. But there are nurse anesthetists out there.
Yes.
Can you talk about, because some people might have an experience with that, and what the difference is there, and what they should think about in those scenarios?
Meaning if you're going to if a practice and has a nurse anesthetist, I think nurse anesthetists are.
What is that? What's the difference?
One is the level of training primarily, and the difference in most of them are dealing with critical care nursing with an expansion into training in being a nurse anesthetist. And then there's a difference in just the training overall between a nurse anesthetist and a physician, just by virtue of just our training and our background. Doesn't mean that one you should not do. No, I don't believe that. There are very good nurse anesthetists, just that they're very good anesthesiologists, and there may be bad nurse anesthetists, just like there may be bad anesthesiologists. And I'm sorry, my dog has just, hi, honey. She's just, sorry.
It's okay, it's the Zoom world. Yes. We're all used to it.
Zoom world. She's sort of there. So I don't think there should be a fear of saying that there's one versus the other. This is just what my practice is. And you'll go places where there, but
nurse anesthetist, there is a physician anesthesiologist overseeing them.
Yes, usually that's what it means, that you have a physician who's overseeing the care. So a nurse anesthetist will be able to go into a room, but you need someone who should be able to supervise, and the physician anesthesiologist will be their supervisor. I don't.
Are numbers around that with, like, what's the ratio usually of a nurse anesthetist to a supervising physician?
I don't know the exact number. I have to be honest with you. It could be
that's okay.
2 to 3 per nurse anesthetist per physician.
Okay.
So then it would probably be a 1 to 3 ratio. And I'm just giving a number just so we'll see.
Yeah, and there's a question about, you know, when are you in the hands of a nurse anesthetist, and would you know that before going into surgery? And I think when I was leaving county, they had started doing that in some places. But when else would someone know, and is that something that they would know? You know, I mean, I know I'm throwing all kinds of stuff.
You know what I mean? I'm trying to. They should introduce themselves. And
Okay.
so that's, I guess that's sort of the practice. And then you'll see me sort of tilt my head like my dog over here. But someone should introduce themselves and say that I am a nurse anesthetist, and that and this is what is going to occur. And I also train my family to ask, who are you? Because maybe I can never speak for myself. And so I had a sister who was at Kaiser, and I've been teaching her, just ask who is doing what, when, and where, and then let them know who your family members are. So they'll have to answer to them too. But it's so the only way will be to ask, and then the institution should be stating that they have a nurse anesthetist that is there. And then you'll have to know that most nurse anesthetists they usually are supervised by a physician of some sort. Right?
Yeah. So that's great. So there's another question, which is also kind of one of the myths that we had talked about, which is around epidural. So this is one of the types of anesthesia that you talked about. And so maybe you can explain exactly what an epidural is from an anatomy standpoint, because I think a lot of people don't know. And then there's kind of those myths around, can it cause permanent back pain or paralysis? You know, what are those things, the bad stories that are out there, and what's the likelihood of that?
Hi, honey, come over here. Some of an epidural is a regional anesthetic, where usually you can put this anywhere from the thoracic level, or people get epidurals for cervical pain from a pain specialist, all the way down to what it is that I might do in labor and delivery. And the biggest issue is, where are you in relation to the spinal cord? For epidurals that are done for labor and delivery, you're nowhere near the spinal cord. We're usually a few levels down. And then for thoracic epidurals that they will be doing for someone who's having chest surgery, they're a little higher up. So they need to be a little bit more steady in regards, because you're a little closer to the spinal cord. And then for people who are getting cervical injections for neck pain, they need to have a fluoroscopy or fluoroscopic guided machine that will guide the anesthesiologist or pain management specialist that's there. As far as getting back pain, it can occur, but that's rare, and it doesn't last. It shouldn't last for like months or years or something like that, not from an epidural. That's one myth that is out there. But it can occur, you know, acutely within a few days. You can have it for a few days or so. The other question was,
I think that was it. It was just about kind of
yeah,
epidurals. And so you talked about the anatomy of that, and then kind of those myths around it, that it can cause permanent back pain, paralysis.
No paralysis. We're not near the spinal cord, usually for epidurals that are done for most procedures that are, especially from the stomach down, you're nowhere near. We're in the lumbar area, and the spinal cord is not there. The cauda equina are a whole horse's tail of nerves, but you won't become paralyzed from it. The only other issue that I do want to bring up is knowing what you're on, because one of the aspects of being able to really give you an anesthetic that is safe for you, I would need to know if you're on things that thin your blood. And those kinds of things make it risky, meaning that you may not be putting a needle, or you won't be putting a needle in someone's back if they're on a drug like Coumadin, or other blood thinners like Xarelto or Plavix. That is a contraindication to doing it, because you can get bleeding inside of the canal, which is fixed, and that can cause problems and possibly paralysis. So we need to know what you're on, and that's very important to give a medication history, because you can't just have anyone going back there to do something. I need to know what you're taking, no matter what it is, including herbal medicines, so that allow me to give you something safely.
So that's a great point. And I think a lot of times some of those anesthesia interviews are brief, and patients feel like, oh, it's probably not important to tell the anesthesiologist. So medications is clearly one of them.
Yes.
Probably some of the herbal supplements that can cause a little thinning of the blood. What are some of those other things that people need to remember or keep in their list for, you know, in case they have surgery and what to discuss with the anesthesiologist? Are there other things that people don't think about and then you're like, oh, I wish you would have told me that?
You should tell an anesthesiologist every medicine and why you're taking it. We are the people that monitor you based on risk. And that risk is going to be based on and tailored to my being able to manage any risk based on your history. So nothing is out of question for you to say. And I need to know the medicines you're taking, no matter what that medicine is, legal or not. Just let me know.
Excellent
Don't
point.
be shy. Do not be shy. Tell me what it is. So I'll be able to give you the proper pain medicines. I'll be able to make sure that you're not getting something that would do you harm, or I can watch out for you. So if you're taking medicine for hypertension, but you haven't taken it for about a month, I will probably be the one who say, you know, well, really, why? Why did you do that? Did your doctor tell you to, or did you just feel like you didn't? And we can go through that kind of conversation. Are you taking medicines for pain to start? And then I can have you continue them. Or it allows us to have a plan that is really tailored to you. And the tailoring really is based on who you are. And you might be someone who's taking medicines. You might be taking herbal medicines that I need to watch out for. I hope that answers it.
Yeah, absolutely. So, so you said you spent a day in the GI lab, which
yes,
that's for gastroenterology, and a lot of colonoscopies there. So, since we're about wellness, and colonoscopies are one of those things that once we reach a certain age,
yes,
we're there. So there is a range of anesthesia that can be done for that, or maybe it's, I shouldn't say that, maybe it's different drug cocktails that can be used for anesthesia. And I know I've heard patients say, you know, you mentioned propofol, which is probably the only drug that everyone knows the name of now. But sometimes it's not part of their plan, or they pay cash extra to get that. Can you just talk a little bit about that whole range of what can be given for a colonoscopy and what we should know about it?
Part of it would be whether or not it is sedation that is given by the whomever is there in the GI department. And that would be, they can give you drugs that are going to cause amnesia and comfort. So you can get usually a drug that is similar to Valium, because everyone, or Xanax, but it's a drug like Versed. And Versed is a benzodiazepine. They can give you intravenously. You'll feel comfortable, but you may not be completely unconscious. So a certain degree of awareness can occur while you're there, but you should be comfortable enough to get through the procedure. Propofol is now a totally different ballgame. And it requires someone who knows how to make sure that when it's given, you know how to breathe, or they're watching how you're breathing very closely with each breath that you take, or not. And that requires, and that will make you more sedate, anywhere from being lightly sedated to heavily sedated, with the thin line between giving propofol and what a general is. You would be unconscious and not aware and comfortable. Excellent. Yeah, and that's the difference. And the same may occur with just the sedation. But once you put propofol in the mix, you need to have someone who, one, knows how to give it, and you can make someone unconscious and they won't know what's going on at all.
Good, which can be very helpful in some of those situations.
Yes.
So here's a question. So obviously, no one ever wants to have surgery, and sometimes things come up, and you do have to have surgery. So what part does your baseline health play in how anesthesia affects you and how well you recover from anesthesia? You know, is it helpful that you are exercising and eating healthy and within a good weight? Do those things have an impact?
Yes, they do. All of the above. All of the above. There'll be those things that make anesthetics in and of themselves, just like health overall, riskier if you are someone whose heart is not functioning as well. If you don't have a good cardiac reserve, meaning that you can run all around up and down steps, which we use in your metabolic determination of how you're doing in your cardiac health. So someone who is able to do those things, then they are probably a lot healthier. And that would be for an anesthetic or surgery or for whatever it is that you are doing. So it really will go the large breadth. So if there's things, smoking is another. Out of all the things that I look at, smoking is probably one of the most important things not to do. If I can give you just this talk on smoking cessation, stop, because it does so many different things. Your reactiveness of your airway, the ease of me being able to say that you can heal properly, or your anesthetic is there, how you breathe. So those kinds of things, if you can deal with health maintenance before surgery, that would be a good idea to sort of get that under track. And then the other, it really.
So cardiac, or I guess even cardio exercise from that
point of view, yes,
is really good. And what about weight or BMI, which is a calculation of where you are on the spectrum of normal weight to obesity to morbid obesity? How does that impact anesthesia?
It impacts the risk of what it is that it takes in order for, how do I manage someone who would be able to, I'll give you an example. I'm trying to, go through all of those.
I love it. It's great. You're doing an awesome job. This is a lot of information.
Thank you.
And you're answering everybody's questions, which is great.
Good. We'll take the spectrum of the ease of being able to get a spinal anesthetic, a spinal performed, even though we now have ultrasound guidance that can help us with all of that. But the ease of being able to say that I would be able to do this spinal, it's more difficult when your BMI is greater, and the ability for me to get that needle in, it's harder, even though I can do it. And so that takes options away that give you the ability to say that I would be able to give you a combination of anesthetics that deal with what we call multimodal anesthetic provision. And I would be able to say that I can give you a spinal with just a small amount of narcotics and get you through the procedure and then get you home. It also makes it a risk for how you breathe, because the larger you are, it now constricts on the aspects of your breathing. So we'll take a woman whose BMI might be in the 20s, and then a woman whose BMI is close to 40, and she's in labor and delivery, and she's going to now she's going to have her baby. And this is some of the most important things that you can think of. Now it becomes the risk factor of what happens if you need to have something done emergently. Getting an airway secure is one of those things. So it changes your risk factor when you deal with obesity.
Yeah, look, I mean, I think that's great. And ladies, we are all about wellness. And even though none of us ever want to have surgery, exercising regularly and staying at a healthy weight is super important if any of those things do come up.
And that's what I'm working on too. So you're not alone. Went out here. Okay,
we're all working on it.
Yeah, we're all working
on
it.
It's
just the same thing.
So you described yourself as an airway manager.
Yes.
So can you talk about that a little bit? Because I know sometimes patients are confused. They'll hear things about different ways to control the airway. There's something called an LMA, and there's something called a tube. And patients have a lot of fear around the tube going in, and what do we need to know about that?
The tube is my best friend. And it allows me to have a level of comfort to know that I can do so many different things from an anesthesiologist's point of view. I know that I can protect you if needed. So it allows me to do a whole breadth of so many things. That being said, when you have a general anesthetic, the depth that is there makes it so you don't breathe as well. you will most probably need a tube of some sort in order to help you breathe. And there are different types of tubes. One would be a laryngeal mask airway, which is a supraglottic airway, glottis being the vocal cords. I have to go back and make sure with my audience. And
That's good. I like it.
Yes, yeah, and the glottis is just your vocal cord opening that allows you to entrain air back and forth, meaning oxygen and exhaling CO2. And if you have a general anesthetic, most probably you need a tube to help you breathe. How do I choose one versus other? The other tube would be an endotracheal tube. That's called intubation. And we've heard a lot about that recently with all that is going on in our world today. Patients that are needing to be intubated. And what does that mean? And regardless of what tube is chosen, that requires a skill set to be able to manage that airway, meaning I have a whole series of algorithms in my head that are with me when I go to sleep and with me automatically that become muscle memory to say that once I put you to sleep, I know that I have to manage your airway. I've got to get something in to manage and help you breathe. That's what I mean by airway manager. And managing of that, I can put an LMA in someone who doesn't have problems with reflux disease, or I can do a simple procedure, someone who is not morbidly obese. And otherwise, someone I would need to, depending also on the surgery, I would have to intubate you, which means I'd have to give you something to make you completely unconscious, something to paralyze you. And this paralysis is where all of the muscles are now relaxed. And when they are relaxed, it allows me to open up your mouth and put a tube through your vocal cords into your trachea, and then allows me to breathe for you. That is intubation in and of itself, but it requires usually a muscle relaxant to go through. And you need to have someone completely unconscious before that muscle relaxant is given.
Okay.
Now, both of those allow you to breathe. So that means that you will be able to get oxygen in, either through a machine that I have to give, or I can just have you breathe on your own to a certain extent. So it's managing the anesthetic. I hope I explained everything.
Yeah, you did. I love listening to you talk about it because it's so much more of an art now than it used to be, where you would just give everything and
no, you give everything
out for the duration, and then it takes them forever to wake up. And now you guys manage it so meticulously.
Yes, and usually in the operating room, it is really the point of getting you into the operating room, coming through, preoperative, your preparation that it takes to get there, then getting into the operating room where we make you warm and comfortable, and then you will go to sleep. The art of it is that your body is a beautiful thing. And so you'll be able to metabolize medicines that allow us to keep you comfortable, keep you without being aware, get you through the surgery, cut everything off, your body metabolizes it, and you just wake up, and then everything is done. And usually we can have that. So once everything is done with surgery, we're actually getting you up, getting you out, and getting you to the recovery room. You may not know that this has occurred until you get to the recovery room or later, but that's the beauty of it. And I've been training at this for such a long time. I've seen so many different things, especially propofol, that allows me to give you something that is quick in onset and turn it off, and you metabolize it beautifully, and then you wake up and everything is done. And also using different adjuncts to it, regional anesthetics.
I love that. And
yeah, so it's
we're coming to the end. We've got a couple more questions.
Oh, geez,
and you talked about
Isn't
that crazy? You talked about metabolizing. So there's a question and then a myth around that. So metabolizing means that your body is breaking down the medicine that you're putting in, right?
Correct.
Okay. And then, so the question is, or maybe it's the myth as well. If you have multiple surgeries, like, oh my gosh, I've had 6 surgeries in my life, and is that affecting my brain? Can I not have any more? Is there a cumulative effect of anesthesia?
No, not that I know of. I think you should. Because I'm in trouble. I've had maybe And so I'm not hoping that, but there always will be the aspect of where you are in time. And that time frame will be where you are and the type of surgery that you're having that will bring on an inherent risk. But having multiple anesthetics in and of themselves, not necessarily so, and in increasing the risk of some untoward events like something with your heart or your lungs or your brain. No, that's a myth. It doesn't occur. But if it's something of where your health has changed, then you're now looking at a different spectrum in time.
And in general, how long after you've woken up from anesthesia, how long does it take your body to metabolize or get rid of the medicines that you've given?
It usually takes just a few hours. It really does. Some of the lingering effects of not remembering, because you can be surprisingly, you're in a place where you're asleep the entire time. So you have no idea what is going on, and hours have literally passed. So there's a spectrum of time that is actually elapsed that now you're probably trying to catch up with. You're in a different environment. It could take a little time, and some of the medicines can linger a little. So we say usually within 24 hours, it should be gone. And also you're taking other medicines. Maybe if you go home and you had surgery during the day, there's something else that you're taking that may make it a little bit more lingering a little bit in how you're metabolizing things. But anesthetics in and of themselves, propofol wears off very quickly within hours. Most of the drugs that we give you, if they're an inhalation agent, within hours it's metabolized and gone.
I think that's such good information for everybody to have. And I have one final question from somebody, which is going to be fun. You're going to be able to tell a story. Before we do that, I just want to let everyone know that these health conversations are recorded. They live on the Women's Health and Wellness Institute Facebook site. They also are on the Providence YouTube channel, so you can watch them there. Next week, we have the amazing Kim Douglas, who will be moderating a conversation with Dr. Adriana Schmidt about dermatology and kind of the risks and myths and everything around that. So Dr. Vidato, here's our last one, and you're going to get to tell a question about this. So You've been an anesthesiologist for 30 years. So this question is, I'm a little anxious, but what happens if you are in surgery and there's an earthquake? And I think this is like such a great fear, and we've all been in those situations where something happens, but I know you must have a story about an earthquake or a power outage or something. Like, let's calm everyone down that we know what to do.
The Northridge earthquake. Do you remember?
Absolutely.
That was way back in the 90s, and I was doing a cardiac fellowship, and I had the drugs in my hand, and I was about to put this patient to sleep for an emergency aneurysm repair. And that's a
big surgery.
Yes, it's a big surgery. It required bypass where the patient would be on a heart-lung machine. And that was, now we're in the operating room and the room is shaking. And this was, now we're getting to the point where we have all these multiple monitors that are all over the place, swinging back and forth. And I'm going, nope, I can't give you this drug. And so I put myself over the patient because I'm like going, he's sedate. I don't know what's going on with this monitor, but I need to kind of, cover him up a bit and figure out what's going on. So yes, I've been in the operating room during an earthquake in the 90s, and it was the most frightening thing I had ever known. But you don't think about that more so than I was going, oh my, this patient's heavily sedated. He can't protect himself. I got to cover him up, and our priority shifted not from the monitors, which we would look at, but what do we do for this guy and to get him to safety?
Yeah, and there are ways, and I think you've been on medical missions, as I have, in places where we don't have the machines to breathe for the patient, and you do everything by hand. And so if there's an earthquake or if there's a power outage, we all still know how to do that.
Yes, we do. And yes, we do. And if I had say for instance, all the power went out in an operating room. Okay, we're sort of going there. We do have
Thank you, Laura, for this question. It's fun.
We do have backups where I have most of, if you're under a general anesthetic, you are hooked up to my anesthesia machine, but I have backup in the ambu bag. I can breathe for you. All kinds of ways we can get around with what is going on. So
yes,
I hope that
think
answers your
that's,
question. Some people are
it was Laura's question, and it's a great question because those are things that people think about, right? It's like, oh my gosh, I'm having anesthesia, and they put a tremendous amount of trust into you because you're taking care of them, and your entire focus, you know, while I'm operating, your entire focus is on them and their well-being and their vital signs, and are they breathing, and how's their heart. And so, you know,
we have monitors that'll, yeah, I'm sorry, I didn't mean to interrupt you, but
no, you didn't. It's I just you know, I think that fear around that is tremendous, and the skill of the anesthesiologist is being able to understand those fears and make a patient comfortable, not only during surgery but before surgery, that I've got you, like I understand what your health is. Yeah, absolutely.
Yeah, I think that one of the things before we kind of get off is that everybody,
yes,
the operating room is really a patient advocate, and advocacy is there from the moment you come into the preoperative area all the way until you're discharged home. There's a lot of advocacy that occurs. And one of the things is that there's different patient advocacy in different ways. But when we're in the operating room, there's a big team effort to make sure that whatever it is that is there for you, that we actually do. And we check each other in so many different ways, where we're watching each other as a group, we're talking to each other as a group. It actually can be a very beautiful thing of what it takes in order to get you in, get you comfortable. And everybody is watching what other people are doing. So you're not just there in your own little world. We talk and discuss and say, this is what's going on. What do you think? How do you feel? And this is how the patient's doing every moment that we're in there. So.
That's beautiful. I'm glad you said that. I agree. It's a team. It's one of my favorite places to be. And,
yes.
And, you know, we are all patient advocates, and the communication of that operating room team is what keeps every patient safe.
It keeps you safe. And that's the biggest thing.
It is. We are so grateful for your time.
Oh,
no, you did perfect.
Yeah.
That was an amazing amount of information.
Okay,
I think everyone got their questions answered, and we really appreciate it, and hope to do it again.
Well, hope to do it again, and thank everybody for your time also.
All right. Thank you so much.
You're welcome.
Good night, everyone.
Good night.